This conference will now be recorded.
Welcome everyone to the ANCAN Advanced Recurrent and something else, Prostate Cancer Group, April 27, 2021. And let's start with, well, I don't have the order in which I recorded everyone, so we'll just start with Bruce Bocian.
Yeah, I just want to let everybody know that I'm working with the University of Michigan on my PSMA test, and they're very acceptant. They have supposed to do about 1,100. I'm sorry, about 1,400. They're at about 1,100, so they have a lot of room available. They're very welcoming. They called me, explained the whole thing. And if anybody's in the Midwest looking for a PSMA scan, the University of Michigan is open. That's all I got to say.
Bruce, do you know if it's the gallium-68 or the PYL?
It's a gallium-68, sir.
Okay, thank you.
So a couple of things, Bruce. Are you a vet? I can't remember.
No, I'm not.
You're not. Okay. And what is the what's the process? Because if it's open, what are you waiting for example, to get a scan? Is there a hold up there? Or?
Okay, first of all, if you and I discussed this in the past, I'm only 0.24.
Yes.
Yes, and so I'm going to get another PSA right before July, and we'll see where it's at then. And actually, just so you know, the test there out of pocket would be about $3,500 if your insurance didn't cover it. Now, with Medicare, of course, it's covered 100%. And in July 21st of this year, I'll be 65. I'll be on Medicare. So I would probably just wait to then to get it done.
Got it. So if you were ready, if you were at a suitable number right now, could you get into the test right away?
Absolutely.
Okay, thanks. Yeah, that's what I was driving at. And then the other thing I was just going to say to you is technically we do have one new person in this group this week.
Okay. And who is that?
It's our trusted active surveillance lead moderator.
Oh, Joe.
The new old guy.
That's right, the new old guy who's never been in this group before. I think we should.
Everything old is new again. All right, Joe, you're up.
I think we should give him credit for that, and except for Bruce, start him off. What do you think?
Absolutely.
I had a quick question for Bruce. Bruce, was there any special criteria that you had to meet to get be eligible for the PMSA? Like,
not that I know of. The nice thing about this group is somebody here sent me a list of all the people doing the tests. And while on this call, I sat and I wrote a letter to each one of them. And University of Michigan and Sloan Kettering responded. Kettering is probably about a little over $6,000, and on the East Coast, and I'm in the Midwest. University of Michigan is probably about a 2.5-hour drive. But as far as criteria, he says even though I'm only at a 0.24, they'd be more than happy to do it because I'm above 0.20. So that was the criteria. Chemical reoccurrence.
thank you.
And did they, I heard that it could go by PSA doubling time as well. If your PSA doubling time is high, they're more likely to take you with a lower PSA. Is that your case? Are you muted?
Yeah, see, and I don't have that yet either. That's what I'm waiting for on this next PSA test in June, because I went from 0.20 to 0.18 to 0.24. So we're going to see what it is in June. And if it goes up, I'm going to go get it done. If it goes down, I'll hold out for a while.
Hey, Rick,
So
would you like
Bruce,
me to go through?
is your PSMA scan as part of a trial or is it normal service?
It started as part of a trial, but they're actually going into. The guy told me that the guy that started this is actually going to try and put the. He's already reached out to make this part of the service.
Mhm.
Yeah,
So-
it was approved in December.
Right,
FDA in December.
right.
No, I'm asking because Michigan has a different PSMA PET tracer as part of their trial.
Yeah. Okay. One is made by. I had a note here.
It doesn't, we're okay.
Yeah, the one in California is made by a generator. The one in Michigan is made by a cyclotron, and that's the only difference is how it's made, but it's actually the same test, and that's what they're kind of pissed off because just because of the generator versus the cyclotron, they said should not affect the fact that it's the same damn test.
Welcome
Any
to
other
the
questions for
FDA.
Bruce before we move on?
Pardon? What was that?
I just said, welcome to the FDA. Have a nice day.
Yeah, exactly, and that's what it was. So,
Len, did you have a question for me?
Yes, I wanted to know if you want me to go through the official interview process with Joe Gallo or skip it.
Well, Joe's new to the group and people should know Joe. So I think, yes, I think we should give Joe full honors here. Full celebratory honors.
True initiation, huh? Okay.
Well,
Yeah.
hey, Captain, full military honors for you.
Semper Fi.
Which means we get into your underwear drawer and everything. It all hangs.
Okay, I should alert you. I've had some technical difficulties with my. No, I'm just kidding.
All right, Joe, first question. How old are you?
76.
Wow, you look good, brother.
Thanks. I'm coming up on 77 this summer.
Terrific. And where do you live?
I live on the wonderful East Coast, Bucks County, Pennsylvania, just outside of Philly.
Oh, yeah, sure. Bucks County. Well, of course, it's a bit of a silly question for you, but I'll ask it anyway. How did you hear about ANCAN?
Oh yeah.
I heard some good things, so I figured I'd give it a shot.
Joe, how did you find us originally?
Honestly, I'm not quite sure. I think somebody gave me a little bit of a lead. I contacted into the organization, probably got a hold of you, and the next thing you know, I was in the active surveillance group, and we went from there.
Okay.
I really don't remember that connection.
Okay.
And Joe, when were you first diagnosed?
It's coming up on 4 years ago, 2017.
Okay, you're making me do math here. And at that time, what was your Gleason score and your PSA level at diagnosis?
Well, the PSA, I've gotten 2 readings on PSA like every time because I get the PSA done as part of my work at the VA, and I also get it done with my local urologist. So at the time, it came in at 6 plus. I don't remember the exact number, but it was 6-ish, which is what when the VA doc said, okay, fine, you better go see a urologist, and I did. Had a biopsy and an MRI done at that time, 3+3, low volume.
Okay.
And you want to know what happened next?
Well, first I'd like to know which doctor you were seeing, which urologist in this case, and at which institution.
Well, his name is Jaffe, Jaffe. Okay, and he is at St. Mary's in Bucks County.
All right.
His dad, I think, used to be a urologist down at Hahnemann in Philly. But this guy's he owns the practice now. Yep, go ahead.
So being that you were only Gleason 6, I imagine at that time they didn't do any bone scan or CT of the chest, abdomen, pelvis. Probably thought it wasn't necessary, correct?
No, the three cores were showing minimal, 15, 8, and 2%. So it was like, okay, we'll do that, and we'll follow the traditional see you in a year, we'll try again. PSA's in between, but at 6 months, or 4 months rather.
Okay, well, I can't follow the usual questions here. So now I'll just let you freewheel it and tell us what has happened since.
Okay, well, and you can stop me along the way if I if I skip over too much.
Sure.
So at about the 1 year mark, I went back, got another biopsy and another MP-MRI. The first MP-MRI came up PIRADS 2. The second biopsy came up the same, 3+3, pretty much the same concentrations in 3 cores. Okay, MP-MRI, PIRADS 2. In each of those two cases, I had genomic testing done with one, Oncotype DX with the first, Perlaris with the second. Both of them, again, came back and confirmed low. Okay?
Good.
The next step that after that, except for PSAs throughout and inching up very, very slightly, because as I said, there was a variation. The one thing I learned real quick is that there's multiple assays that are employed depending on which lab. And so at one point I'd have the lab would show the one that had 6.1 or whatever, and I go to the other one and it was 4.45 with no, with being aware of no adverse activity prior. And that was consistently the way that the two labs have been running. So what we did is just kept our eye on it. It went back to another MRI last summer, back in August. And again, that came up PIRADS 2. And so I had, by good fortune, if you remember back, we had Antonio Westphalen in to do a webinar for us on MPs and MRIs rather. And so I didn't have to coerce him. I asked him and he immediately checked out all 3 of the, or he got the results from all 3. I was able to send him over the images. There's a service out there that they use called Pocket Health that actually, excuse me, stores the image and the hard copy report. So I was able to send it over to him immediately one night, figuring he'd get back to me, and he did. In just a little over an hour, he came back and said, I've discovered that there's just one ill-defined focus that looks to be, the second one he couldn't get the image up, but from the first and the third MRIs, and he said, they're the same, no change. He said, but because I can see it, I would categorize it PIRADS 3 instead of 2. Okay.
All right.
Next step was with my Bucks County urologist, went in, got the PSA, and my number had jumped to just a hair over 10. He said, uh-oh, we better, get alert on this. We'll check it out. He said, maybe we should do a biopsy, but maybe we should also monitor a little bit. And I think what maybe have compounded the situation, he decided that I should go on finasteride, which then, can distort your PSA values.
So you went from PSA 6 to 10, is that right?
Well, actually, it would have gone 7 to 10. The 6
7.
had up to 7,
And
and it
what
went
period of time?
a little over 6 months.
Okay.
Okay. And so it's but in conjunction with that, I had been under consideration for a wellness trial at Fox Chase in Philly, Fox Chase Cancer Center. And I was chugging along with all the background and the whole schmear for that. And then Andres Correa, the doctor from down there, called and said, "Uh-oh, we got a problem." I said, "What?" He said, "Well, you've gone over the 36-month time limit that they would allow for an active surveillance person." And I was just outside that window. He said, "So you are not going to be able to get into the trial because Northwestern is, I guess, sponsoring it." However, I had been talking to him about exploring the micro ultrasound. And so he said, "But I can put you on the list for the micro ultrasound and work you in because, he said, I'd still like to see how that goes." So the micro ultrasound was done just last month. And the results of that, the one thing I can say, because a couple of guys were asking, like the micro ultrasound, it produces a real-time image. The doc can see it, but he actually can play it back, and he played it back for me. And we were able to together look at the one lesion that was identified. And he said, "Okay, with that, we've got a little bit of concern. We might need to biopsy it, but I think what I want to do is we'll get a biomarker done." So we did the Select MDX. Apparently, I couldn't get into an Echosome DX because apparently they won't run it for anybody who is on active surveillance. They'll do it if you're beyond that stage. Okay, so we did the Select MDX. That came back. Of course, it says, "Well, you got cancer." Well, good, we knew that one. And the probability of having something greater than a 6 came back with a low 70%. He said, "So I recommend that we do a biopsy." I said, "You're on." So last week, I had a transperineal biopsy done, and I can tell you that the procedure was effective, but the answers were not liked. I didn't care for them. I had one that was targeted. We used the micro ultrasound device to target that one, and that came back as a Gleason 8, 30%, and the rest he did as you would do a normal TP, only because he said if I do it all with the machine, he said it's going to take us 2 to 3 times as long. It's apparently not easy to do with the machine itself. So we did 15 cores total, and of which 4 came up with 4 plus 4 concentrations of one was 50%, the other one was 20, and it was like a 10 and a 2. And they were all in the same general area. So it's likely that we're looking at the same lesion that's being assessed. So with that, he says, "Okay, fine. Then what we should do is take the next traditional steps, get the CT and the bone scan, which is scheduled for this Friday. However, in the meantime, I'm also part of a group over at Zero called 50 Vets in 50 States. And so I became aware of the fact that there was actually a PSMA PET trial going on out at the West LA VA. That's essentially UCLA. And that they were open to veterans joining in. I sent them an email at the end of last week, and yesterday I scheduled my visit to West LA on the 18th of May. And that's the PYL version of the PSMA PET. Okay. The one thing about the PSMA PET also, if folks are not aware, the longer term objective is to not only use it, it lights up smaller quantities of the of prostate cancer more than what you would get out of the bone scan and the CT, the soft tissue. And you know, he very politely said, "That's old school. Now that we've got the PSMA PET," he said. So the gallium-68 and the F18 PYL is the way to go. The longer term objective is to not only use it to identify and light up the occurrence of any of the cancers, they're also looking to, I don't believe UCLA is doing it, I can't tell you for sure, but it's the VISION trial where they're going to then try to use lutetium-177 to actually target the cancer. So besides having it identify it, it should also attempt to zap it. I'm not sure how far along that one is. I'll probably know the next time we talk because I'm going to try to do a little more work on it. But that's the radionuclide approach.
So, Joe, the key here, and what I'm hoping you might get from some of these guys, I'm just not sure. You know, the issue is obviously how to treat a high-risk tumor like this, with the objective that you don't come back and talk to us again in a recurrent stage. And what's obviously unique about, not totally unique, I've seen it before, a situation like yours is you have a very small amount of cancer, maybe 70 millimeters by 150 millimeters roughly. And so it's attractive to consider focal treatment. But there again, we know people who have had focal treatment for higher risk, like 4+3 and 4+4, and it doesn't work. And then they finish up having to do more treatment. So I think from your standpoint, attending this group, is there anybody in this group who did first target their cancer with focal and then found that it recurred and they had to follow up with another treatment? And if there is, maybe you can tell us how much cancer you had originally.
Mm-hmm. Well, I'll be glad as soon as I get the results of the first test out there. I'll have that more definitively to share. And you know me, I'm going to be doing my homework and knocking on a number of doors to get a lot of input. The one thing that I found out is in both cases, UCSF, our good buddy Peter Carroll is on top of what's happening with the gallium-68 or 38 rather, and I can tell you that he's going to get a call somewhere along the line too.
Along the line. Is there anybody in this group who first started with focal therapy and then graduated from there?
Yeah, go ahead, Jake.
Well, yes, I did back in 2010. We thought it was my cancer was confined. It was Gleason 8, but they thought it was confined to the right side. So I opted for focal cryotherapy, where they freeze half of it. But unfortunately, that did not work. It had already metastasized in my case. Micro metastasized is the term. So it didn't do me any good. And I don't think there's a whole lot of people that like to do focal anymore. They still consider it experimental in a lot of cases, even with HIFU and all that stuff, and they still don't. My understanding is it's not a recommended treatment in these days.
Well, it is. And again, I'd encourage you to listen to John Horton's presentation, which is very worthwhile. I mean, it is in certain cases. The question is, what are those cases? Usually 3+4 is a max, but there are, what was your Gleason, Jake, originally? Your mutant?
The original?
It was
The original.
8. Did you say 8?
Yes.
I'm eight in this. Oh, I'm sorry, Jake. I'm sorry.
It's all right, Joe.
Yeah. Yeah, so you
Getting
were
old,
an
I
8, and
can't.
how much cancer was there, Jake? Did they think?
I don't remember, Rick, to be honest. They thought it was a pretty small percentage, in the
Right.
20% range.
Yeah.
I mean, most of my cores were Gleason 6, but all it takes is one Gleason 8, and that's
Yeah, I mean, and this is something, and I know Joe's going to be very diligent, but this is something that Len and I have both said to Joe, that it's very hard when you have a Gleason 8 to
Yeah.
be sure that it's only in one place, because it could be in other places and it just might not be seen, and you don't want to fool around, as you well know, don't have to tell you, you don't want to fool around with the Gleason 8.
correct.
Well, in speaking with the doc who's leading the one out at Los Angeles, we had a bit of a discussion, and he feels that we're going to have a very much better handle on what the conditions really are after the PSMA PET is run.
Great. That's,
Yeah,
I mean, I was
let
going
me
to say,
say,
I
Rick,
think,
that it was Rick's radiation oncologist, Mac Roach, who said in a webinar that really impressed me, that if you have, first of all, prostate cancer is a multifocal cancer. And if you have confidence that there's only one focal occurrence, it probably doesn't need to be treated. And so your other option, if you're going to treat at all, treat the whole prostate gland, because chances are there's more than one focal lesion. That was his opinion.
Well, he's also on my potential to call list,
Oh, good.
because I think he's pretty damn sharp. So I
he
got
is, and let me know beforehand, because he's tough to reach. But we, as Herb would tell you, we can get to him, so we could help you if you, as and when you want to speak to him. Give me a heads up.
And I would also second the idea that he's really incredibly helpful and knowledgeable.
Mhm. Well, I've only seen him in various video presentations, PCRI and such, and enough that I just said, this guy's good. He's a straight shooter and he knows what he's talking about. And those are the people I like to talk to.
I mean,
He's direct.
the one thing that I do wonder, there is some element, even though we love PSMA PET, that it is not 100%. There could be non-PSMA positive foci.
Mm-hmm. I'm aware of that. I just know that the PSMA PET is only going to give me a higher percentage than what I'm going to get Friday from the CT and the bone. But yeah, I realized that it's not an absolute. I am seriously going to be talking to a lot of people, and Rick knows that the reason I'm here tonight is because I want to continue to get as much input as I can. And the reason I went like the day after I got told about my my biopsy, I went to my AS group and I told them, because I believe in sharing and gaining as much information on both sides of it as you can. And so I'm open to everything, and I don't want to be playing around, but I also don't want to get into Panicville.
Joe, if I can make one other comment, the only reason I opted for focal therapy back in 2010 was I was still young and I wanted to have wanted to maintain a sex life. Of course, that has long since gone by the wayside. But you know, that's the only reason that my doctor didn't want to do focal. He didn't think it was a good idea, but he said he would do it because it was so supposedly confined to the one side of the prostate. But you know, like I said, they were trying to spare the nerve. But I'm guessing in your case, that's probably not an issue anymore.
How do you know?
I don't know. I said I'm guessing. I know it's not an issue with me. I've been on Lupron for 10 years, so sex, what the hell's that?
Yeah. Yeah, the only determination that I pretty much made is, which is probably not an issue coming up anyway. I'm not planning on getting cut.
Yeah.
Joe, the one thing I'd like you to clear up for me, you said you're going to UCLA for the PYL, is that right?
Yeah, actually, it's being done under the auspices of the West LA VA, but that's because they share the same property. They're working with UCLA. It is an official trial. I can't remember the doctor's name now, but yeah.
Okay, because the FDA approval at UCLA was gallium-68, but this is different. Okay.
Yes, this is the F18 PYL, and they did a first phase with, I think it was like about 200 and some guys, and this one they're looking to do about another 200. They're targeting, as I understand it, to try to see if they can go in for approval by summer.
Yeah, I heard that too. PYL should be approved this summer. And when it is approved, it'll be widely available. Unlike the gallium-68, the PYL is has a longer half-life, so there's no urgency once they generate it to administer it, and it's just easier to generate the radio tracer.
Correct. It's got a half-life of a couple of days as compared to a couple of hours.
Yeah.
The one advantage that I do have, and Rick almost got into telling it again, if there is anybody that knows a veteran, you do not have to have recurring disease, okay? And the only cost that you would have to look to incur is to get there. There's no cost for the study at all. But you got to be a vet.
Well, that's great. Anybody have any questions for Joe? Or is there anything else you wanted to add, Joe?
No, I don't think so. If it comes up, I'm going to hang around for the rest of the meeting. So if it comes up, I'll bring it up. But if anybody else thinks of anything or wants to get a hold of me, I'm joeg@ancan.
All right. Well, thank you so much for sharing this new information with all of us. We're all pulling for you.
Thank you. I appreciate that.
Well, that's for sure, Joe. We're all right here for you. If you need anything at all, just holler.
Ready to turn the meeting on. No. By accident, I was trying to get out of your United Healthcare. Oops.
Okay.
How about if we move to Jake?
Okay, thank you. Exactly 3 months ago, I got my last infusion of docetaxel. I was having side effects and it wasn't working, so we stopped it. Today, I got a new oral chemotherapy, a new old chemotherapy drug called cyclophosphamide, and I took my first pill at 3 o'clock today. I took my dexamethasone at about 6 o'clock, and it hasn't killed me so far. I was just getting ready to grow my hair back and my beard, and I suspect that I'll be losing it again. I'll have to get my son to give me a buzz cut. That's all I had.
Okay, well, good luck.
I think that's under 30 seconds.
Good luck with the cyclophosphamide.
Yeah, and well, obviously we're all hoping it's going to give you a great result, obviously, Jake. But we're also very interested in cyclophosphamide because we don't know anybody who's had the experience. One thing I hear right away that a question is, you only have to take the steroid after, you don't have to take it before, huh?
Well, according to the trials that I saw, yes, you take they said they would give the cyclophosphamide in the morning and then the steroid in the evening. No mention of, premeditation or anything.
Right.
So
Okay.
Actually, Rick, I did know someone at the S2 group in Danbury at Ann's place who was on low-dose cyclophosphamide, long pre-treatment history like Jake, and he did okay on it. He tolerated it quite well, and he got at least a year or so out of it.
Fantastic.
good. I'm hoping for the same.
Okay. I mean, that's good. Really, really good.
All right, questions for Jake? All right, how about if we go to,
Stay strong, Jake. That's all.
Thanks, Herb. I'm going to try. Before we go on, Len, can I touch base with somebody on the telephone?
sure.
Joined us a few minutes ago. Would you like to identify yourself? You called a few minutes ago on the telephone.
Or could it be somebody who's on the computer and also on the telephone at the same time? Is there anybody who's using the phone as well as the computer? Okay.
It's all right. Just, you're welcome to stay. Just, we won't know who you are. That's all. Thanks.
All right.
Very welcome. Please, anytime you want to speak up, speak up. Otherwise, please stay through the whole meeting.
So Jake, it's Ken.
Hi, Ken.
Hey.
Is that it, Ken?
Oh. I thought you were going to ask me a question.
No. That's
You're caller number
not
2.
it.
Is that you on the telephone?
No. What's that?
Never mind.
No, I'm not caller number 2.
Caller number 2 is not lighting up.
Yeah, that's not me. I just wanted to say, I know we chatted this morning, so you just started it today. I didn't think you had. So when do they think you'll get results?
I don't think anybody knows. I'm guessing hopefully within 2 weeks. Herb probably knows better than that. The reason I waited, I've had the medicine since Friday, but I had to wait for the dexamethasone. Specialty pharmacy screwed up, and I didn't get that until today. So I wanted to take the two together.
That's the good stuff. You want that?
Yeah, I know. It's going to make you happy for a little bit. But what was your PSA recently?
My last one about 2.5, 3 weeks ago was 373.
373.
Yeah. So I'm sure it's higher than that by now.
Yeah, well, we'll be thinking about you.
Yeah, thanks. Thank you, Ken. And thank you for confusing me with the telephone and everything, because I had no idea what was going on there for a minute. Thank you for that.
That's all right.
Well, Ken, your turn.
Mine is just
Should we come back?
Yeah, let's come back in after the next person.
Okay. I wanted to touch base with Dennis Correa. I think we couldn't reach you before, Dennis. You have anything to say tonight?
No, I don't need any time, thanks.
Okay. Ken, do me a favor. Whenever you are ready, just send me a chat message or send it to everyone. Let's go to Les Shelderup.
Okay, I just had a question about, there was some thought about going to a second line anti-androgen. And I'm still debating that, but the question I had is what real benefit is there to going to that now? That is, what do you see different? Quite often what we go by the PSA, we measure PSA and testosterone. Those are the main ones that I track anyway. But what will you see different if you add a second line anti-androgen?
Well, the goal is that you'll have a longer period of undetectable disease compared to just the first line anti-androgen or the first line androgen deprivation drug.
Right.
So you won't see anything different?
No.
At all?
Well, you can't really attribute the change, if there is one, to whether it's the second line drug or the combination less. So, I mean, you can't, but the goal is obviously a more durable response.
So let me just clarify that slightly, Les. There may be one thing that you can see depending on which drug you use. If you use Zytiga, and if you're monitoring your testosterone, you may see a lower level of testosterone when you add Zytiga to your LHRH. And we've seen guys where that's happened. So they may be trundling along in the 30s or something like that, and they add the abiraterone, and all of a sudden they're looking at a testosterone level around 10. But as far as I think you're asking, what are you going to see in your markers? Sometimes your blood markers are going to change a little bit. That can happen. But as Herb rightly says, we're never 100% sure if that's from the LHRH or if it's from the abiraterone, because it's very hard to do. It's very hard to do a double-blind test on the same subject. So, right, Herb?
It's very hard to do, and the data we have are where they compared monotherapy with an LHRH drug versus both, and the combination prolonged all the parameters you could hope for.
But
so for systemic disease, it's so strongly indicated.
Hello, guys. This is Jim Marshall, and I have a testosterone now of 0.025. So far, I've been on the Abby for 47 months. Okay, and the Lupron.
Now, hold on a second. Was that testosterone or was that PSA?
That was testosterone. Okay, and the PSA is a 0.01.
Wow. Okay, I've never heard anything that low. That's unbelievable. Incredible, Jim.
Well, I mean, I have to say mine comes back below the threshold of measurement.
Okay. Are we all using one issue I always have to ask with testosterone is are we all considering the same units? I have a feeling that Jim's units may not be the units we usually use.
Okay. What are the units that you use? Okay, and I will check it.
We're used to nanograms. I think it's nanograms per DL, deciliter.
Okay, I will check it.
Yeah, yeah.
Jim, what is what is your Gleason score?
Let's see, a Gleason score was a 7, 3 plus 4.
Okay, yeah, let's keep in mind, guys, just to keep things honest here. I could easily see a second-line anti-androgen having a long, durable remission with someone with a Gleason 7, maybe not so much Gleason 8, 9, or 10.
Mm.
So your mileage may vary depending upon your Gleason score, for sure.
Great point. And again, let's all be sure we're talking same units, because
Yep.
we may have to multiply that by 100, 10 or 100 or whatever it is. And I know we've had that issue before on this call, so I'm just waving a little bit of a red flag. Either way, it sounds pretty low, Jim, and thank you for sharing that with us.
Well, this is Les again. I have a Gleason 10, but every time that I've been on either Eligard or Lupron, it instantly, within the next 6 weeks, which is the period that I normally take it, it always brings it down to either less than 0.1 or at 0.1. And the testosterone is, down in the range where they just call it, well, the last one was just less than 8. So apparently that's as low as they can measure. So when I'm on Eligard now, my PSA is 0.1 and testosterone is less than 8. So if I would go to a second line anti-androgen, would I see any difference, or just, trust me, it's better for you?
I mean, you're certainly, if you're 0.1 PSA, it's hard to imagine you're going to see it. You can't see a big difference.
Well, that's the point.
Right.
Is there any point to going to a second line anti-androgen at this time when my readings are about as low as you're going to get?
Well, I think here's the reason, here's the concern, Les, that your disease goes back a ways, and you've been on and off LHRH drugs. You've had a holiday, started to rise, you came back on, you respond well to the LHRH. And that's what's happened right now since you've been back on whatever it is. I'm just looking at my notes, but it's a few, when was it you went back on?
I think it was beginning of December, if I remember right.
Right, back on Eligard 1220. Yeah.
Yeah.
So since you're a good candidate for intermittent, we could make the hypothesis, because that's all it can be, that if you drove down your testosterone even more and you drove your disease down even more, you could get a longer holiday when you come back off. That's the first thing. The second thing is, we know as a rule from clinical trials that men with the type of disease that you have generally have better overall survival when they add a second line anti-androgen. So, the best knowledge is it will do something. Will you see it? You may not. Are we sure? No, we're not, because you might just get the same. Okay. But the best knowledge and the best advice says this is the right thing to do.
Okay, so you can't count on seeing any difference. Just historically, if you add this at this time, chances are your outcome will be better. Is that?
Well, look, if you take a specific case, I mean, we're again, and Herb can do better explaining this than me. When we do these trials, we have a bunch of subjects. And so we have statistically reliable data, meaning, and you're an engineer, so you get this, meaning that this is the most likely thing to replicate, the most likely circumstance to replicate. When we talk about an individual, we never know. And when I've got an individual who says, well, my testosterone is 8 and my PSA is less than 0.1, then there's nothing we can do to improve that. Well, maybe we can. Maybe we could get your testosterone down to 6 or 4, which would be very marginal and probably make not a lot of difference to the disease. But there's nowhere for you to go with what you see. So you can make the argument, well, you know, I'm as low as I can get. Why bother adding it? Well, the reason to bother adding it is that we know that when men added it, they lived longer. So, you know, you're weighing up, will I live longer versus am I going to see anything?
Okay.
I defer to my two scientific moderators here because that was a very pragmatic, heuristic approach.
No, I mean, I think this, you know, we're talking about the Stampede trial, which compared monotherapy versus dual therapy and showed you live longer. And, you know, they didn't present data by data of PSA 1 versus 0 because they didn't do it serially. But the data are pretty convincing that the combination is better for advanced disease, metastatic disease.
With low volume,
Right. Well, even high volume it showed.
Yeah.
Les, what we can say for sure is for someone like you to be, the standard of care is to be on a second-line anti-androgen. Okay, so whether or not you decide to do that is up to you and your doctor. You do have an unusually, remarkably responsive cancer to just first-line LHRH agonist or antagonist. So you are unique. I think it's reasonable for you to forego a second-line anti-androgen until you see some movement of your PSA. That yours is certainly not the typical experience of guys with Gleason 8, 9, 10. They typically don't have as durable a remission as you for all these years on just the first line ADT drug.
Right.
So,
well, that's why I was proposing or saying, if my body reacts in a certain way, why not take advantage of it and hold off until something else happens? You know, I don't know. It's not that I am against going to a second line anti-androgen or even going to chemo if I need to. It's just I'm trying to figure out, is this the time that I need to or not?
right. I think it's reasonable. You know, there is a concern of overtreatment, possibly.
Yeah.
I want to, Peter Kafka sent me a private message saying he wanted to hear me talk about my experience on a second-line anti-androgen, namely darolutamide or Nubeqa, because that is the only drug I'm taking. I'm not taking a testosterone suppression drug like Lupron or Firmagon or Orgovix or whatever. And it's my PSA. It's going as the last Lupron shot I got was back in May of 2020, so it's just about a year now. And my PSA has remained below the detectable limit down here in Florida, at least, which is 0.06. So what are the advantages of that? Well, clear-headed. I don't have Nubeqa or darolutamide doesn't penetrate the blood-brain barrier. So I don't have the ADT associated brain fog. As far as physical fatigue, again, because I'm not taking an ADT drug, I don't feel as fatigued as I did when I was taking both Lupron and the Nubeqa. And also, Peter wanted me to ask Jim Marshall, Jim, are you only on Zytiga, or are you taking an LHRH drug as well?
Right now, I am on the Eligard, okay, and the Abbey, and I have been for the entire time since the Latitude study closed in June of 2017, and I started at August the 1st.
Okay, so there you go, Peter. Okay, any questions for Les before we move on?
What I'd like to ask the guys is there anyone else who's had the same thoughts as Les? Or is there anybody in a similar situation to contribute, to help with this thought process for Les?
Les, this is Al Latimer. I was on ADT alone for like 15 years, and my PSA was less than 0.1, and my testosterone was very low. I mean, it can, I don't know how long you've been on it now. And I was a Gleason 9, so, but I tried intermittent a couple of times, and every time I stopped the Lupron, my PSA started rising immediately. I mean, it was there. I never had a holiday. I don't know if you've tried intermittent or not, but to me, if I had other drugs back then, I would have tried to push my PSA as low as I could and see what happened. And if I had a second line drug to do that with, I would have done it.
Yes, I have been on a drug holiday twice, once about 2.5 years and the other time 2 years. And it did eventually start going, the PSA did eventually start going back up at its usual rate. Usually when mine gets loose, the doubling time is 6 weeks. So once it gets going, it goes up fairly rapidly, but it stayed low for a long time.
Hi, it's Larry. Hello?
Go ahead, Larry.
Yeah. You know, I see complexity in this conversation. There's one thing, I mean, we're looking at the data that shows that adding a second line anti-androgen has a general increase in lifespan for them, but that's in kind of epidemiological evidence that's based on looking at the evidence overall. We don't know that everybody who added a second line lived longer. Maybe some of them would have lived less or not longer. So you're looking at a general solution, and here we have an individual case which may not be related to the general situation. Maybe Les is better off just taking a single primary anti-androgen and avoiding, although we don't know the kinds of side effects that may take place with having two anti-androgens, that he's avoiding that additional, nothing is for free. And on the other hand, the evidence looks like he's taking, if you play the odds are that taking a second one would improve the majority of people. But it's everybody's case is individual, and you're working with doctors, hopefully, who are pretty sophisticated and knowledgeable, and they can view these trends of the hundreds of patients they have and see that maybe it's okay to stay like this for the time being and keep watching it before adding a second line. It may prove just as valuable or more valuable. I can just refer to my case where I have a PSA that's been fluctuating a little bit, but for the last 4 or 5 years, I've stayed on just Lupron. It went up for a while, stopped Casodex, came back down, and now it's been slowly rising, very slowly over 4 years. It's gone up to like 0.4, 0.4, then it goes to 0.5, it goes back to 0.4. My doctor doesn't know that this is related to the disease, and we're just watching it right now. We go on monthly PSAs and track the trend very carefully. If we start to see actually a 3-step trend up, we definitely will immediately add. Our plan is to add darolutamide and get scans again. But for the time being, I stay in this kind of advanced cancer active surveillance on one anti-androgen. And I think it's complicated. I think can't be sure, and I have the same issues or questions about Prevenge, which seems like it would be a good time to take it. Evidence shows, but on the other hand, cases are individual. So I just think about the complexity of things and the quality of life and the amount of times that you go for things and the kind of side effects. And we've seen many people who followed this wait and see attitude and had bad results. So I don't know. I'm not against what Les is doing at all, and I'm not especially in favor of it, but I think it seems like a good decision if he thinks he has a good doctor.
I have a question basically and a comment, a concern that I have. Does anybody know the percentage of people on second-line anti-androgens, Xtandi, Zytiga, whatever? How many people develop an AR mutation once they've been on it, like I did? That would be my concern for Les starting it sooner rather than later. If it was me, I'd wait till later, and I told him that. But does anybody know what percentage of patients actually get AR mutations where these second anti-androgens are no longer effective? Does anybody know the answer to that?
Yeah, I don't know the answer, but I do know that it is correlated with the length of time you've been on the second-line anti-androgen, so that the people who have been on it for lengthy periods of time are the ones that tend to develop untreatable mutations.
Yeah, but let's keep it. That's you, Rick, isn't it? Oh, whose phone is ringing?
That's mine.
It was less. It was less.
Yeah.
Okay.
Yeah, I got.
So let's keep in mind that these AR mutations, or any mutation in any pathway of cancer proliferation, they're not just limited to second-line anti-androgens. They occur with first-line ADT, LHRH drugs, which is why people become castrate resistant. So it isn't as if, if you stay on an ADT drug, that you're not going to have any mutations.
Well, in my case, Len, I became castrate resistant on Lupron, so then I started going to the second line anti-androgens, and I got a good run out of Xtandi. I got 30 months, but then somewhere about the 24th month, I developed an AR mutation, apparently, give or take a month or two, and so none of them worked for me after that. And that's my only concern with Les, is that he starts it too soon, and then runs the gamut. And depending on how long his doctor would want him to be on a second line, 6 months, a year, 5 years, I don't know.
Well, what you're talking about, Jake, was addressed in an interview between Chuck Ryan and Sweeney, whose first name escapes me at the moment. Sweeney at Harvard.
Chris.
What is it, Rick?
Chris
Sweeney, right. And they specifically talked about this concern that most oncologists had originally, that, hey, wait a minute, we're telling people to start these second line anti-androgens earlier. Are we going to start seeing mutations and resistance occurring sooner? And they both agreed that they have not seen that. For what that's worth, that was their opinion.
Well, they should touch base with me then.
No, I'd second what Lynn said. I think the mutations or the resistance to androgen receptors forms when you're on Lupron. So, I mean, I can see a significant decrease in testosterone by switching Lupron out for, abiraterone. My T levels on Lupron were around 20, and as soon as I went to Abby, it was below 1, and it's been that way for the last year and a half.
I just
So
want to.
go ahead.
No, come back in when you're ready, Ken. I just want to clarify one little point, that the trials for and actually I should really let Herb do this, but the trials, the Stampede trials were randomized trials. They were not epidemiological trials. I know what Larry Fish is saying. It's what I said earlier, which is when you take a whole group of people, randomized in this case, and you derive a result, that is the general result for all those people. But an individual can always respond differently to the group. That still makes the group a representative sample and a reliable sample. Right, Herb? Did I say that right?
Well, it does, but again, the Stampede trial was not for castration-resistant men. And so, if we're talking about how fast you might see an ARV7 mutation appear, it's not, the data aren't there. I just tried to find any data, and they're not there. But my suspicion is it's correlated simply with how long the tumor's been around and reproducing, and the pressure you might put on from either ADT or any of these drugs. So I'm not sure that adding, the answer for me is I'm not sure that adding a second line drug is going to speed up an ARV7 mutation or speed up your castration resistance if it ever happens at all.
Well, it's more than just ARV7, Herb. I mean, I found out I had a number of AR mutations, and I found out from my foundation liquid biopsy. And I don't have ARV7. There was several other ones. So, again, it was just a concern that I wanted to bring up. I think it was worth discussing.
Well, I mean, these drugs are targeting androgen receptors in a way, right? Reducing testosterone essentially means you're not agonizing the androgen receptor. And so the tumor seeks a way to get around it, right? And that's what the mutations mean. But again, Jake, I'm not sure it's correlated with the way you suppress the androgen receptor.
Oh, okay.
All right, guys. Excuse me. Let's go to Paul Frieda.
Hi there. I have a friend, a neighbor, a very good friend, who's just been diagnosed with prostate cancer. He apparently his PSA went from like 10 to 30 quickly, so he's panicking. Anyway, he needs a PET scan, and the insurance company has denied him. I'm wondering if you have any ideas of what he can do other than file an appeal.
Who's his doctor?
Well, he's just got started. I don't know who his doctor is, but worse than that, he has a urologist, and the urologist has not even suggested that he go to a medical oncologist, much less a genitourinary medical oncologist. So he's in the early stages of discovering what he has to do. And but right now, the immediate problem is he needs a PET scan to find out if and where the metastases are, and the insurance companies turned him down. And he's not, he's a very passive sort of guy. So I need to get some suggestions for him to make sure he can get the PET scan.
I mean, my suggestion, Paul, would be...
Hold on a minute, Herb. Let me first say, Paul, we always get into trouble here when we're talking for third parties. And frankly, it's not something I really like to do in this group, because first of all, right now we're working without full information. What was his Gleason score?
I don't know his Gleason score.
Okay, so that, for example, we have to know that, because if his Gleason score was a 4+4 or greater, it's standard of care to get a PET scan. If he's gone from 10, and if he's high risk, which he is, it is standard of care. And the NCCN guidelines show it as being standard of care because he's high risk, because his PSA is greater than 20. And all he's got to do is tell them this is the standard of care. He's entitled to a CT scan. I say a CT scan and a bone scan. Now, a PET scan is something different. I don't know. Did he have a CT scan?
I don't know that. What I do know is that they put him on 3 drugs: Lupron, abiraterone, and I think bicalutamide.
Okay, so again, it really doesn't work when we're working through somebody. It doesn't sound. First of all, if they put him on Lupron and bicalutamide first, and then Lupron and Abi, hopefully, he shouldn't be with a urologist at this point anyway. He should definitely move. If he's talking about a PET scan in terms of a PSMA PET scan, then yes, he can get it, but it's complicated. And where he gets it, is he a vet? Is he not a vet? Where's he going to go? We don't know what sort of PET scan he wants. And without knowing that, and without knowing what they turned down, if it was an Axiom scan, how old is he?
He's 87 years old.
Okay, so if it was an Axiom scan, he's entitled to an Axiom scan. It's Medicare approved, and that's the type of PET scan. So there's a lot of factors in here, and it's going to get lost in the translation if we go to you and you go back to him.
Okay.
I mean, the best
Rick,
thing
I would say there's one overriding message. This guy needs to get to a GU medical oncologist who will know what to do.
Correct.
Okay. Yeah. I gave him my GU med onc, and hopefully he'll contact him. Okay. I thought someone might have a simple solution, like he could get, there's some charity that will help you with a scan if you get denied or something like that.
But we don't even know what he's looking for. We don't
Well,
even
he doesn't
know
know what he's
type
looking
of
for. He's just listening to the urologist.
Okay, but we don't know what type of PET scan he's looking for, Paul.
Okay, all right.
We don't know, we're on a wild goose chase here because we don't have the right information or enough of it.
Okay.
Yeah, let's move on. Got a bunch of guys I need to check in with here. Joe Murgia, do you need time to talk tonight?
No, nothing for me. Thank you.
Okay, thank you. And Vince Wilmot, do you need to speak tonight? Vince, are you there?
I think he left, Len.
He's been in and out about 3 times. He may have gone out again.
Yeah.
Okay.
Sorry.
What about Stan Friedman? Is he with us?
Yes.
Yes, I have nothing. Thank you.
Okay. Ravi, you need time tonight?
No, thank you.
Is he with us or did he drop?
Yeah, you just got to know thank you.
Oh, I didn't even hear. Okay, thank you.
Thank you,
Pat Martin?
No, I'm good.
And Bill Franklin?
I knew you were going to ask right when I took a bite or something, man. I do have a question for the group if you've got time, but it's not real important.
Okay, we will get to you, but first let's go with
and John and Len. John A just arrived. John Antonucci.
Oh, yes. Hey, John, do you need any time to talk tonight? Can't hear you. Well, still can't hear you. Thumbs up or down? You need time tonight, John?
He's unmuted now. Maybe we'll hear him.
I think he was unmuted before.
No, can't hear you, John.
John, either reboot or try calling in on the telephone.
Or just shake your head, yes or no.
No, he already said he wants
said he needs time, but we just can't hear him. Let us move to Frank Fabish.
Hi, got my sixth chemo treatment on Thursday. So I made it through those numbers. It has hit me like a ton of bricks, this last one, and I'm trying to work through it, which I will. But hopefully each day it will get a little bit better, and as I move further away from the chemo date. Positives, PSA continues to go down. Even though it only went down a little bit, it's still trending down. I went from 0.16 to 0.14. My white blood cell count, hemoglobin, and platelets are all within the range that they expected. And so they're satisfied with that. Next up on my calendar is a pretty big date, May the 11th, which I will get a nuclear bone scan and 2 CT scans. And that's going to determine how effective the chemo was on the nodules on the lungs. I'll be meeting with my doc, my oncologist, on the 18th of May to review the results of the scans and what has to happen next.
Frank, have you had any of the big time side effects after 6, like neuropathy in your feet or hands, or edema, swelling of the legs, or the thing where you cry? It feels like you're crying rain all the time.
Yeah, the eyes water continuously. My nose runs continuously. The main effect, again, is, as I've talked in the past, is the taste and the lack of being able to eat. And I've lost about 35, 36 pounds through the process, trying to stay as healthy as I can. But it's only going to be time from everything that I've seen. But the bigger question on my mind is, what's the impact going to be on the nodules on the lungs? To me, that's the most important thing to me right now, is where are they going to be? I know future plans with my doc. I mentioned before I'm on Relugolix in place of Firmagon now, and I know my doc in the past has talked about if everything's okay from the chemo, to start me on apalutamide in combination with the Relugolix. So that will be based upon the scans and the results. But the main thing has been the weakness of the muscles, the fatigue, and the taste. I have a few aches and pains, few pains in the hands, legs, but nothing that I can't work through. They're intermittent, and at least they're not regular.
Yeah, Frank, it's Ken. You know, I'm getting ready for 17 here Friday. The
Wow.
nah, definitely the fatigue you can improve by just just by going out for a walk. The dry eye is easiest just by taking these eye drops, Clear Eye or any of those. They help because the problem with your eyes is that they're just drying out, and you just need to add a little bit of eye drop solution to your eyes, and it helps a lot.
Yeah, I've been using eye drops as frequently 2, 3, 4 times a day. And I also understand you lose all the small hairs up in your nose that
you lose hair
causes more drainage.
everywhere.
Yeah.
I'll be walking outside and I can feel the wind blowing across my eyes. So, because I don't have any eyelids. But the fact is that the dry eye is from chemo, and you have to supplement it with the dry eye solution. You can either get a prescription brand or you can get just over-the-counter Clear Eye. Fatigue, though, you just have to push through it. You have to go for walks and don't sit down and say it's okay. I mean, I just came back from 7 days in Idaho of fly fishing, so it's doable and you can do it.
Well, I'm focused on the endpoint and the scans right now, and hopefully the chemo is in my rear view mirror.
Well, keep our fingers crossed.
Yes, especially from somebody that's had 17.
17, and he still goes on 10, 20-mile hikes. It amazes me how Ken can do that.
Hey, Ken, I got a question for you. How many trout did you bring back, man?
Sorry, I can say I caught quite a few, but they were all small.
Oh.
So I didn't really bring any back because you can't freeze them.
Okay.
Right.
Okay.
Let's go on now to Al Latimer.
Hi, everyone. I guess you remember I had a PSMA PET at UCLA back at the end of February. Dr. Scholz, who has been my primary oncologist, recommended that I start Provenge, which I've been working on. And in the meantime, MD Anderson got back to me and told me they wanted to come to Houston and have a biopsy, among other things. And Dr. Scholz totally dismissed that idea. He said, if you've had the liquid biopsies, the biopsy is not going to tell you anything more than what we already know. My wife and I decided that we wanted to hear what Dr. Logothetis had to say at MD Anderson anyway, so we went there a couple weeks ago, went through all their testing and the biopsy. The biopsy did come back positive for prostate cancer, and I'm waiting for the results on the molecular profiling that they're doing. But so my question is, is this a common attitude that the physical biopsy is not necessary if you've done liquid biopsies? Because Dr. Scholz was very adamant about it was a waste of money and it was a waste of effort for me to go do that. And I'm wondering if anybody else has experienced something like that.
Well, I think the general consensus is that tissue biopsies are still the gold standard, but it depends how old your tissue sample is.
Well, this is brand new. I just had it.
You just had a tissue biopsy.
Yes, last week, 2 weeks ago at MD Anderson. And Dr. Scholz told me not to go, not to do it. It wasn't going to give me any information that we didn't already have.
Well, what was the result?
Well, I don't know yet. They're waiting for the result to come back.
A month already?
It's been, at this point, it's been 2 weeks.
Oh,
They said it was that it was slow right now. It's going to take it 3 weeks or so for it to happen.
Well, we'll be very interested to see how it compares with the liquid biopsy.
Yeah, yes, for sure.
What did the liquid show?
Well, it's consistently showed I have a BRAC2 mutation, and I've been using Lynparza for the last couple of years, which has failed now. And so I'm waiting for that for the for the microbiopsy to come back and hear what Dr. Logothetis has to say about what I should be doing going forward, whether the Provenge is the right next step, or he has something else that might be, I don't know, better, more aggressive. I don't know.
So, I've got a couple of things.
What did they biopsy?
They biopsied a lymph node. They biopsied a lymph node in my neck, right there. It was.
Sorry. This was a soft tissue biopsy. I thought they were talking about a prostate biopsy.
Oh no, I don't have a prostate.
Okay, well that's what I was about to ask you. So, excuse me. So this is so that what they wanted to do was a lymph node biopsy.
I'm sorry. Yes, I didn't say that quite specifically enough. Yes. So I had the PSMA test. I had a number of lymph nodes that lit up, and MD Anderson wanted to biopsy one of those lymph nodes.
So let me address that.
Dr. Scholz said it was not.
Right. Let me address that, Al, to cut to the quick. In my opinion, having been educated by Foundation Medicine, so I'm not a doc, but I've sat through a lot of education. Dr. Scholz is wrong. The best biopsy results come from soft tissue samples. The second best biopsy results at this point probably come from liquid biopsy. Thank you. So probably come from liquid biopsies, and the third best come from bone. And the reason why bone is the worst of the three is because the maceration techniques which break down the bone in order for them to analyze the DNA can sometimes impact the results. And they don't have to do this maceration. Again, Herb's much better informed on this than I am. But what they can draw from the liquid biopsy is pretty good, and what they can find in a soft tissue biopsy is the best. So, is it going to make a difference if you had just had a liquid biopsy versus a soft tissue? I would say unlikely. That's my guess. Having said that, it is going to give a better result. Does that summarize? Does that answer your question?
And I must admit, I agree 100%. If Logotheus at MD Anderson, who's like, if you've ever listened to any of his presentations to other medical oncologists that find him to be at the very top of his game, you would understand that if he represents, and I have clients here in Phoenix that are bazillionaires that fly their own planes to see this guy. If I could have got him as my doctor, I would have. But honestly, if he recommends doing something, I would take it as the best, without doubt.
I just have to tell you, Ken, if it were me, I'd take Corn over Logothetis any day. But
I
that's
know,
just a
I
matter
know
of
Dr. Bogathius has been like chair of the department for the last 15 years, so maybe he's been out of it a little. But if you hear his presentations to other medical oncologists in regards to prostate cancer and how it develops and how it's defined, I mean, the guy is brilliant.
Well, Dr. Scholz is no slouch either. I was just curious as to why he would be so adamant about it being a waste of time.
Well, you know, I think
Anyway,
I think one reason for that, Al, is because he's not thrilled about people getting second opinions on his treatment. I mean, you know, I hate to say that, but I do think that's a factor.
That has occurred to me. Anyway, we went ahead and did it anyway. And I'm just waiting for the last piece of it to come in. They did the liquid biopsy as well. I mean, they did everything they could think of, and we'll see what they come up with.
So Pat, so you already know you have a BRCA mutation, correct?
Yes.
So I'm assuming that Scholz, you know, felt that it's not going to really change your treatment plan.
He thought that there wasn't
cancer, and you know you've got a BRCA mutation. I get where he's coming from. It's not going to radically change your treatment plan at all.
Yeah. What if he has another mutation, Peter? What if he has MSH6? And what if it didn't? And what if, you know, what Al's doing? I mean, I see where he's coming from. He's looking for on the margin, and maybe the liquid didn't turn over the other mutations, and maybe this will. Your BRCA, your liquid biopsy was done by whom?
I've had several of them done by Foundation has done them.
Most recent, when your most recent, Al?
Most recent, I don't remember. I have to look it up.
Okay, were you MSI high?
It was about 2 years ago, I think, the most recent, maybe a year and a half.
Okay,
and
so
I think
in other words,
it was probably Foundation.
Okay, and at that time, were you MSI high?
I don't know the answer to that.
Okay, and have you? And as I recall, the BRCA is you're not responding as well to the PARP inhibitor now as you were. Is that right?
That's correct.
Right. So if you haven't had an analysis, if you haven't had NGS, next generation sequencing, in a year and a half, and you're not responding to the ALFRED the way you were, to me, I definitely would have another sequencing. And you know, did Scholz offer you another sequencing right now? Did he say, okay, guys, rather than you going there, let's do another blood draw and do another liquid NGS?
No.
Yeah, well, I think that to me, Scholz is wrong there, because it's a year and a half gone by. The disease has changed. We don't know exactly how the disease has changed. We know it's changing because we know you're becoming BRCA. You're not responding in the same way to the BRCA. And I think it makes perfect sense to do NGS sequencing a year and a half later. Now, whether we do it with blood or whether we do it from soft tissue, we can argue about. But having said that, the best way to do it is soft tissue. So for me, you know, that's 2 black marks against Scholz, not 1.
So to me, I want every little bit of information I can get at this point. The biopsy in my neck was really, the setup took 3 or 4 times as long as the actual biopsy. It was really not that big a deal. We'll see. But anyway, I went ahead and did it against Scholz' advice, and we'll see how mad he gets when he finds that out.
Well, I mean, I think the point you make to Dr. Scholz is, Dr. Scholz, it's 18 months since my last, and I'm not responding to the ALFRED right now. Don't you think it makes sense to get another next generation sequencing? Don't say soft tissue or liquid or whatever. Right. Don't you think it's time for another next generation sequencing?
Yeah, that didn't come up in our conversation.
Right. Hey guys, we're beating this to death, I think, here.
Okay,
let's move on. We got a few more guys to get to.
I was just wondering if this controversy had come up before, so I think I'm done. Thank you.
All right, thank you, Al. I want to get to Julian Morales.
Hello. Yeah, I'm just bringing an update. I had my biopsy done early last month, and came up with a 4+4. The rest of them were 3+3. There was only 1+4, and I sent it off to Johns Hopkins, and they came back. It's really a 4+5. So I've had a Lupron shot, 22.5 milligrams, and I'll be taking another one in 3 months. I went to see my PCP today. He's taking a PSA and a testron to see where we're at on that. In the 6 weeks after the Lupron, I'll have the gold seats in place and probably starting EBRT sometime in late May.
So you're having brachytherapy plus the EBRT.
No brachytherapy. No, the Lupron. I don't know if that's called brachytherapy.
Oh no, I thought you said something about seeds.
ADT.
Oh, I'm sorry. Okay.
Okay.
Okay. So the standard of care today is more than just EBRT, Julian. The standard of care for 4+5 disease, and how many cores were positive?
You were going to ask me that. 7 cores.
Out of how many?
Out of I think 15 altogether.
Okay, so there's probably a fair amount of cancer. The standard of care is either SBRT plus IMRT plus ADT. It's not, or brachytherapy plus IMRT plus hormone therapy. It is not the best results that we see come from that combination. It's not just IMRT plus 8 hormone therapy. Now, you may, it's possible, I'm not sure, but you may be not a suitable candidate for treating the gland. I would, with SBRT or brachytherapy, I doubt it. But I can certainly tell you if it was me, in fact, it was me because I had 4+4 and that's the treatment I got and it worked, is I would not be doing IMRT alone if I could get SBRT plus brachytherapy to treat the gland. And I would, if it were me, I'd be putting a hold on that. I'd be talking to more docs. You're on the path, but I don't, for me, IMRT alone would not be enough.
When you say IMRT, it's the same as EBRT, right?
Well, in fact, EBRT is not as advanced technology as IMRT. The fact that you're talking EBRT makes me question the equipment that they have, because people don't really do EBRT anymore. They do IMRT or IMGT.
Well, I think the EBRT is just a general category, Rick, for any type. It's just external beam. Basically, it's any radiation that's not breaky.
Well, yes and no. But usually they use EBRT where it's not image guided. That's the difference. I wouldn't agree with you that it's the same. They usually use external beam when it's not guided.
So do we know where he's getting treated?
I beg pardon?
Do we know where you're getting treated? Because
Houston,
EBRT is def. Go ahead.
Houston, their literature says IMRT, and some of the other literature says EBRT.
Yeah.
Oh, it's probably IMRT.
Oh,
And they're using
so
a
can I ask?
Let's hold on before. Let's go back to Ken's question. Where are you getting treated?
Houston Methodist.
Yeah, I don't know. But they're stating IMRT is in the literature. I mean, I'm sure it's IMRT. So it's probably intermodulated radio
I
therapy.
want to raise this with someone because it's actually pertinent. But I suggest you go back. Who's the radiation oncologist?
Dr. Dr. Twisha Verma. She actually came out of MD Anderson.
How do you spell the last name?
VERMA.
Okay. And how many sessions are they talking about you getting?
39.
Okay. So do you know if this includes them radiating the pelvic girdle?
Yes.
Okay. So what I would do if it were me is I'd go back to Dr. Verma and ask Dr. Verma why they cannot give you SBRT or brachytherapy and just do somewhere around 25 sessions.
Now, Rick, this is Ravi. I might add that we had this discussion about my own case, right? And there was a perfectly good reason why
Yes.
SBRT could not be done.
Yeah, well, but that's why I said to him at the beginning, Ravi, maybe there is a good reason why they cannot do it, because I had you in mind. But what he needs to do is drill down and find out if there's a good reason or there isn't. Because if there's a good reason, you know, I agree. But what we're trying to get you to do, Julian, is drill down and find out if there is a good reason why. Do you have any medical history around your, you know, your lower trunk?
No, I had a CT scan and a bone scan, and both came up negative.
Right. But do you have any medical issues, you know, hernias or anything like that?
This is the only medical issue I've ever had other than my asthma.
Okay. So I think Ravi's exactly right. We asked Ravi to go back and to you know, be sure that he wasn't a candidate, and for solid medical reasons he wasn't a candidate. But there are two reasons why we're pushing this. One is it's much more convenient for you because the first 20 to 25 sessions could be taken care of anywhere from 1 to 4 sessions, or 1 to 5 sessions, 1 to 4 sessions. So that is convenient for you. The other reason is because the research shows better results. And so we need to know why Verma is suggesting this. And without mentioning any names, I will make a call or send an email tonight to somebody and see if I can get a better handle, and I'll be back in touch with you.
Okay.
Specifically, but that doesn't stop you being your own best advocate and asking the doc why the heck they've chosen this treatment plan.
Okay.
Are you good, Julian, or have any other questions for us?
No, that's it. I just wanted to get some thoughts on that, and that you pointed me in the right direction.
Okay.
But I will be on ADT for a year and a half. You had asked me that last time, Rick.
Yeah.
Great, yeah, and
Every 3 months.
right, and that's really a minimum for 4+5. Some docs will give you a little more, but I'm glad that they're talking 18 months, and you know, you see where you go. I know if it was me and I was feeling okay at the end of 18 months, I might push it out a little more, but I think 18 months is a minimum.
No, Rick, I would just add maybe for him to make sure he asked his doc to pull testosterone levels, because a lot of guys don't do that, and docs don't think of doing it.
Yeah.
Well, no, I had that was done that today. Had my PSA and testosterone done today, so I have those results.
Good.
Yeah, but did you have a testosterone taken before your first? When did you get your first shot?
About 4 weeks ago.
Did you have a testosterone taken before that shot?
No.
Again, we always recommend that you get a testosterone so you know your baseline.
Yeah. I was kind of perturbed that he didn't do that.
Okay, well, don't be perturbed. Tell him.
Yeah. I told him, I said, why didn't you take a testosterone? He said, well, I want to see what the Lupron did, that we do use that as a baseline. That kind of just threw me for a loop when he said that.
Yeah,
sorry,
makes no sense.
Just repeat what you just said.
He said he wanted to see what the Lupron would do in about 6 weeks, and then we'd go from, and he would take a testosterone at that time to see where I was at, and that would be the baseline.
Right. I mean, and that's what a lot of docs say. But we have found, our experience has been that if you know your baseline, it puts you in a much better place when you come off of the testosterone.
Right. Off the ADT, you mean?
Sorry, when you come off of the ADT. Excuse me.
Yeah. That's okay.
Yeah. Correct.
Okay.
I knew what you meant.
Guys, it's 8 o'clock. We're going to move on. Peter Monaco, you had a question for us, or an update.
My drug holiday ended last month, and my PSA jumped up quickly from 0, then to 0.7 to 1.7 in about 6 weeks. I've already had bone scan and CAT scan ordered by our friend Dr. Shao. They came back negative, but based on what I'm hearing tonight, I don't even think it's worth getting those tests because nothing's showing up, and something must be somewhere. So I guess I'll push her for the PSMI test, I would assume.
PSMA, yeah.
Yes, PSMA test. Would that be what I should be inquiring? I haven't seen her yet, nor spoken to her. This has been all done through her staff. They called me when the results of my last PSA test, well, the one I was still down in Anna Maria at the time, they called me, hey, it went up to 0.7. Can you come in and we'll do a CAT scan? I said, well, I'm still in Florida. I'm going to be here for another month or so. So they said, okay. So we set it up for the 21st of April. So I had a PSA test and a CAT scan at Sloan down on Basking Ridge. And the PSA came back. It jumped from 0.7 to 1.7. The CAT scan came back negative. I had a bone scan done at Hackettstown Medical Center. That came back negative. So what's next? What should I be telling her?
Well, the gold standard, of course, is the PSMA PET. If for whatever reason you're unable to get that quickly enough, the Acumen scan would be the next best choice for you. But that's definitely FDA approved and available in many, many places. But try for the PSMA PET if you can.
I think the PSMA PET might be across the street at Weill Cornell.
Yeah, he's not. He doesn't go to
Oh, he's not in New York?
Downtown. He doesn't go to Manhattan.
Oh, sorry.
He doesn't go to Manhattan.
Not that I can't. I mean, I can, I can drive to Manhattan. It's not a big deal.
Apparently, Margulies is trying to look at an integrating PSMA PET and MRI simultaneous.
Wow.
That's something that he's playing with.
So do you think there are trials available that Peter may be eligible for at Weill Cornell?
I don't know, but if I see
I
anything.
do think there is one at Weill Cornell that I think he could be eligible for. And I think if you check it out.
So who would I inquire with about that? Through my oncologist or go there?
I mean, I can do it. I'm trying to locate the clinical trial number now, but basically you can search for Weill Cornell PSMA PET under clinicaltrials.gov.
Okay.
So a couple of things, Peter.
Mm-hmm.
The first is, please don't get too anxious. Please.
That ship has sailed, Rick.
Well, then we got to work with you to bring the anxiety down, and hopefully you're doing some exercise every day because that's going to help you. But we really want you to sit on that anxiety the best you can. Secondly, yes, a PSMA is the gold standard if you can find a place where you can get it. We talked about that a lot today, and I'm assuming you're not a vet. Are you a vet?
No, I'm not.
Okay, so if the PSMA is the best, but with a PSA of 1.9.
1.7, but it's probably 2 point something
Call me
today.
Fisher. Sorry, I did write it down.
That's okay. It's probably
Okay.
2 something today, so it doesn't matter.
Okay.
That was a week ago. The way this thing is going, I don't know, it's probably 100.
So with a PSMA of 1.7, you're very likely to get a result out of the Axumin. And that's really what you want. And then somebody like Peter Kafka, who got a result out of his scan, PSMA or Axumin, is going to give you, or some of us are going to give you thoughts on the best way to attack the disease if we know where it's coming from. Okay, and that might be anything from, in the worst case, chemotherapy, to the best case of doing some spot radiation.
Right.
So we just don't know where to go because we don't have enough information, but we got to get that information, and we've got to get it sooner rather than later. And in a case like yours with a PS of 1.9, my view is, I'd like to hear what Len thinks, and Peter, it's not worth making yourself crazy to find the trials for the PSMA when you can get an Axumin test set up tomorrow.
Yeah,
Well,
I agree with Rick on that.
Now, first, I want to say, Rick, the worst case isn't chemo. I mean, there's much worse scenarios than chemo. So, I mean, chemo won't kill you, but definitely don't let it get, and I go crazy all the time. So I understand crazy, but don't let it get to you, that's for sure. Because chemo is manageable it is manageable. So don't let Rick tell you that's the worst case.
Okay.
It ain't fun, Ken.
Let me just say, let me just respond to that, Ken. What I was saying is, in a case like Peter's, where we have a good handle on where he's coming from, the treatment options that are likely to show up, that would be the worst aspect of treatment that he would face right now. And the best aspect of treatment would be spot radiation. I don't think there's anything worse than for Peter than chemotherapy right now. I'm not talking about outcomes or anything else. I'm just talking about treatment options.
All right, all right, all right.
I was assuming that Dr. Shao is going to put me right back into hormonotherapy. Is that not what I should be expecting?
Well, first you want to get the imaging done, Peter, so that they know where the lesions are. And you can get, as we said, you can get that Axumin scan very quickly in a matter of days. But I wouldn't wait, certainly wouldn't wait weeks, to get into some PSMA trial.
Right. Now, Dr. Shao should order this Axumin scan for me, right? I mean, they have that equipment?
I would think so.
I'm not sure. I've got a horrible.
If not, they should refer you out, and it should be within like a week. They should be able to get you an Axumin scan. So,
You got to speak up and ask for it. Don't wait
Yeah.
for the doctor to order something.
And I've got a funny feeling that they don't like to do Axumin at Memorial Sloan Kettering. That's sticking in my mind. If anybody's on the call at Memorial Sloan Kettering, tell me. But I seem to think that it's tough to get an Axumin at Memorial Sloan Kettering. And you're just going to have to say, then you please refer me out. I want an Axumin done as soon as possible. And you're eligible for it.
Yeah, at Sloan they are difficult about getting an Axumin just like that. They don't just throw them around. Usually they're
well, it's a $3,800 scan, so
yeah, they're
they
very they're cost conscious in a lot of ways. They have their price for a PSMA PET is the maximum price in the country, like $6,500 or something. And no, even if you're in a trial, you can't get like any break on it. So I think Axumin, they do them. They can do them. I might be scheduling myself for one. I might be able to, but it's hard to work your way into it. They're always trying to do like bone scan and
Hey,
Axumin is FDA approved, Larry. So they don't take a financial hit if they administer the Axumin scan.
Oh, they don't? Yeah, because they always talk about, being reluctant, you're eligible, we can work on it. But that's not what they're...
Lynn, I think they do because they're required by Medicare to only charge so much. So I think they don't have an unlimited number that they can charge Medicare.
But I do know that Rick is right, or whoever was saying, that they're kind of reluctant to toss those out.
Yeah. And Peter, I'm pretty sure Larry just confirms what's in the back of my mind. You've just got to say, this is what I want, and I want it quickly.
Okay.
And you have to stand up for yourself on this. And let's find out where that cancer is, and then we'll talk with you about how we're going to get. They'll tell you what they want to do. We'll tell you what some of the guys have done in similar situations, and we'll get you to the right place.
Okay.
Hey, this is Bruce. I posted the contact information for the University of Michigan. You can probably get in there pretty quick based on what the guy told me. I know it's not on the East Coast, but if it was me and I was in your situation and I had to travel from the East Coast of Michigan, I would do it. Reach out to that guy that's on that contact list in the chat box, and he may be able to get you in right away for a PSMA scan.
Great. Yeah, that's a very good suggestion. Bruce, do you know what's the cost on that one?
If you're on Medicare, nothing. If you got to pay out of pocket, it's like about $3,500. Okay. That's if your insurance doesn't cover it.
Right. So there you go. And we know, so you got those two choices. And besides, Peter's already in Jersey. He's already crossed the GW. So it's closer for him than most people.
Hey, Michigan's beautiful this time of year.
Yeah. Haven't been there in a while.
Ken Anderson, I want to touch base with you again before we close out. Ken and Bill Franklin, I'm afraid we only have time for you.
I can give you my only comment was don't be scared of chemo. I'm getting ready to do round 17, and I just came back from a fly fishing trip in Montana, in Idaho. So, I would say don't be afraid of chemo. It is tough, but it holds your PSA down. And I must admit, Paul's call that, it's my maintenance plan is absolutely true. I've been on it for a year and a half. So I don't know. Can I do it another year? I have no idea, but I'm going to give it a whack.
Right.
Ken, did you want to give us your update or wait till next week?
Lynn, I don't really have one. I don't have labs until after my next round of chemo. So I'm at like 20. I've dropped 2 points the last round of chemo. I don't really have anything new.
Okay. Well, that's good. Bill, you rarely have questions for us, so go ahead.
Yeah, I was wait a minute. Yeah, I was talking to someone else, and they were looking for information on I think it's hydrogel, the stuff for the radiation that
Right. Spacer.
I didn't know what to tell them. Spacer hydrogel, is that what you said?
Spacer is the brand name for it. It's the hydrogel.
Space Or. Yeah, I think that was the one.
Yeah, it stands for Space Organs at Risk.
Right. And Bill,
that's actually inserted or surgically,
Bill,
or
the best. Bill, can I just say the best call for that is really the low intermediate, and not this call.
Right.
Yeah, I was just looking for the name and stuff because I didn't know.
Yeah.
I'll go do my research.
Yeah, I have, we have some knowledge around it. Some docs promote it, others don't like using it. It's still not clear why. But I would really raise that on Peter's call. There's probably more experience there than there is here.
It is Medicare covered.
Yeah, I didn't use it when I had my radiation treatment. I didn't even know. I didn't even hear about it. No one mentioned it to me or anything. So.
It only got Medicare approved.
Yeah, Bill, my guy and I think he's been doing it a long time. He said it depends on your
anatomy.
Anatomy. Thank you, Rick. Yeah, and if you have some issues that require you to use spacer gel, then yes, you should use it. But a lot of guys don't. So it's not effective if you don't have a problem where your prostate and the rest of your stuff is sitting. So it's all individual.
Yeah, for me, they just folded up a piece of cardboard.
Put it in. And shoved it somewhere.
You want to patent that, Peter?
Guys, a couple of things, and I'll let Peter. First of all, John, I'm sorry. We do have the 10-minute rule. You got to be here in the first 10 minutes, and we just ran out of time, and we can't continue because the room's getting used.
I can wait till next week. Sure.
Next week, it'll have to wait till next week. Sorry, Carlos, Sylvester, Kang. We are. This meeting starts at 6 o'clock Eastern and not 8 o'clock Eastern. So please read your reminders. Tuesdays and Thursdays are 6 o'clock starts. Okay. So sorry that we're just finishing. We'll be going about 2 hours.
I no longer get reminders. I just have the blop on the computer and I tune in. But thank you. I'll write it down.
You reminders come through the email.
I no longer get emails.
Oh, you no longer get email?
No, I have the icon on the computer that I get. But I do get the sessions rerun, but I don't get.
Okay, let me check about that. Let me see what's going on. If you get the reruns, okay. I just want to remind you all, I put it in the chat window earlier on. I'll put it in the chat window again for good order's sake. We have 2 events coming up this week. On Thursday, we've got this great session we expect with Dr. Fong, and we'll be talking about things like how can we turn a cold tumor into a hot tumor, because the reason why immunotherapy isn't working that well for prostate cancer is because it is a cold tumor. So
what time is that, Rick?
Sorry?
What time is that?
It's at 8 o'clock Eastern.
Okay.
Okay, 8 o'clock Eastern, and you'll need to register. The registration is right there, so I encourage you all to register. It's going to be worthwhile. And then tomorrow night, and I don't have that I can tell you where to get it. God bless John Ivory, who's been working so hard on this. We have our second Marsh performance. I can tell you that it is going to be a very, very touching and poignant session tomorrow night. It is at, I hate to tell you what time back east, it's at 7:30 Pacific, 10:30 back east. We've got a performer who lives with multiple sclerosis. She's going to tell a story, a very significant story, and she's going to tap dance, believe it or not. We're going to interview her. And so that link John has just put in the chat window for us too. And so that's it. And back to Len to close us out. Oh, next meeting, Len, you're telling when the next meeting is.
Next meeting will be Monday at 8 p.m. Eastern.
Len, are you beyond your philosophical mindset, or are you still in that philosophical mind space that led us to Lord of the Rings?
Hopefully I'm always there. I had relapses.
Okay, because you got Peter worried because he thought he was the only philosopher amongst us, and we're posting his stuff. My apologies to Peter, because what Peter wrote in the blog is what he wrote, not what I wrote. I was just commenting on it. But when you write stuff like that, you got Peter shaking in his boots.
Competition, huh, Peter?
I don't mind it. I don't mind it.
Okay, guys.
There's room for 2 philosophers.
Okay, that's okay.
I'm gonna end the recording here. Anybody who's here for the 8:30 meeting, you'll have to relog back on. Our